Hi everyone, welcome back to another Clinical Reasoning VMR. Today we're very thrilled to have the one and only Dr. Conan Liu. Many of us probably know him from his YouTube channel and the amazing learning and videos that he does. Um, uh, uh, he's such a great clinician and educator. I've personally benefited a lot from his videos, and I'm so happy to have him here with us today. So, Dr. Liu or Conan, would you like to introduce yourself and tell us a little bit about yourself?
Yeah, sure. I'm first of all, I'm very happy to be here. I've been listening to clinical problem solvers quite a bit, throughout all of residency and after finishing training. So it's exciting to be here. I am a little bit intimidated, of course, because some of these cases can be very difficult. So we'll see how it goes. But yeah, I'm a hospitalist currently. It's my third year as an attending, so still pretty early on in my career. But I feel like clinical problem solvers is a great platform. It's very open to people learning and being open with things that they don't know. I think it makes a really supportive environment for continuing your own medical education journey.
Oh, that's nice. Can you tell us about like your journey into like YouTube and how did all this start?
Oh yeah, so I think I started my YouTube channel in like 2007 or so. I used to play a lot of video games. I actually played video games professionally for a year. And so I was making all these video game videos all the way back in 2006, 2007. And then eventually, I went to med school and I was like, oh, maybe I should just make some videos about the things I'm learning. And it just kind of progressed over time. I just kept making more and more videos. I found that I really enjoyed making it. And yeah, it's kind of just taken off from there.
Wow. Like I didn't know that you started like from like 2007. Um, I'm a huge fan of the new series that you're doing about the clinical pearls that you share. So yeah, I hope to see more of them coming. And next, I'm gonna introduce our case presenter. We have Yusuf. He's one of the CP Solvers leaders and he's a star. His contribution to this community has been phenomenal. I personally aspire to be like him. He's an amazing educator as well. So, Yusuf, would you like to introduce yourself?
It's awesome. Gonna make me blush. Thank you. No, I'm also a hospitalist. I work at Emory in Grady, which is an underserved hospital here. Conan, I love your channel. I also watch it all the time, especially like at the gym while working out. I was like, oh, some fun pearls. But I have to pause. I'm like, oh my God, do I have to add his Anki card to my Anki card? So it's like a triple layers of Anki. It's so much fun. And everybody is in the comments is saying that, oh, they love your channel. Would love to hear from the people who are helping make this happen today. Sam, you want to introduce yourself?
Yes, thank you, Yusuf. Thank you, Dr. Liu, for being here. I'm Sam. I'm a fourth year medical student at Tufts University up in Portland, Maine. I'm going into emergency medicine, and I actually just got to express my gratitude for the CP Solvers community today during my residency interview. So just thank you all. And I got to, talk about how much I love learning with everyone. So um, I think, Shreya, you're doing teaching points?
Yeah. Hi everyone, I'm Shreya Upadhyay. I'm a medical graduate from Nepal. I'll be doing teaching points. I'm really excited for our discussion today because Dr. Conan is here and we all love his YouTube videos and they are very helpful and they are very practical. So yeah, I'm looking forward to this session.
Thank you, Sam, and thank you, Shreya. So, without further ado, we can start. We can start the case.
Awesome. So I would love to simulate your job as a hospitalist. So you're doing a hospital medicine consult service, and this is from my last week actually on the wards. So you get a call from the ortho team, and the ortho team wants to consult you for tachycardia. So you open the chart, it's like 6 p.m. in the evening. You're like, okay, this patient has no past medical history, was hospitalized for a motor vehicle accident, and they had a right femur fracture. This hospitalization, so maybe 3 days prior. So you review the chart, and the patient is tachycardic to around 120. and has been like persistently tachycardic for the last day. So you tell the team like, hey, let's just give 2 liters of LR and I'll see the patient in the morning. And I'm gonna pause there.
So Dr. Conan, what do you think of this chief complaint, and how do you approach tachycardia?
Yeah, well, this is definitely a kind of consult question that we don't get infrequently. And I think immediately after a post-op patient, actually, I don't know if they've done surgery already, but with a femur fracture, if they have had surgery, the immediate thing I would be thinking is of the risk for PE. And then with femur fractures, you also have to consider the risk of fat embolism, which I personally haven't seen, but is definitely something to consider. And then it sounds like we have pretty limited past medical history. But I definitely think, just with any case of tachycardia, you should initially get an EKG right away just to see, is this sinus tach or is this some kind of alternative arrhythmia that's going on? And so, yeah, those would be the first things I would be looking for.
So like now if we're talking about like, is it a sinus rhythm or not, or a different type of arrhythmia, how would this like change your management or approach to the case?
Yeah, well, I mean, a lot of times people will have AFib, and so we're gonna, manage AFib very differently than if they have just sinus tachycardia. That's all of a sudden, I would still be concerned for a PE. The other thing is we want to make sure that, they're not having AVRT or AVNRT, because those are tachycardias that we could manage with alternative medication. So like with those ones, we would try vagal maneuvers, adenosine. So really knowing whether it's sinus or not is going to be very important.
Back to you, Yusuf.
Yeah, so the patient had already had the surgery 3 days prior, and I can share my screen for the EKG. So this was the EKG, if you can see it. I'll give you a moment before I give you the read.
Yeah, so just whenever I'm reading EKG, I like to go through a systematic approach. And so the way that we typically teach people to do it is rate, rhythm, axis, intervals, and then morphology. So just starting with the rate, you just look at the QRS complexes and you count how many big boxes there are in between each QRS complex. So I'm counting 1, 2, 2.5. So 2.5 big boxes, you do 300 divided by 2.5. And I'm getting that's 120, which matches what was presented to us earlier. The alternative is that you could count up all of the QRS complexes and then multiply by 6 to get the rate. And then the second thing is rhythm. So we want to check if this is sinus rhythm or not, and if it's regular or irregular. From what I can tell, it looks pretty regular to me. And then the first lead that I like to look at is lead 2. And so in lead 2, I want to look for an upright P wave before every QRS and a QRS after every P. And so far, it does look sinus to me because I see a P wave before every QRS. And then axis, usually to determine if it's the left axis deviation or right axis deviation, I look at lead 1 and 2. And so I'll put a left thumb up if it's positive in lead 1, and my right thumb up if it's positive in lead 2. And if you have 2 thumbs up, then it's a normal axis. So we have normal axis here. If it's a positive QRS in lead 1 and it's negative in lead 2, then you have left axis deviation. And then if it's negative in lead 1 and then positive in lead 2, then you have a right axis deviation. The next thing you want to look at is the the intervals. So when we're talking about intervals, we're talking about the PR interval, the QRS interval, and the QT interval. So the PR interval, we're going to start at the beginning of the P wave, and then look at the end of the the start of the QRS, And that shouldn't be more than 5 small boxes. If it is, then you have a first degree AV block. Here we see a normal PR interval. QRS shouldn't be bigger than 3 little boxes. And so here we have narrow QRS complexes. And then QT interval, sometimes we just can kind of to roughly eyeball it. You can look for what's called the R to R interval. So you look at one QRS and then you compare it the distance to the next QRS. And if the T wave is less than 50% of that distance, then that's saying that you probably don't have QT prolongation. And I wish I could kind of show this to you guys with my mouse or something. It might be kind of hard to just visualize when I'm just explaining it like this. But yeah, so all of the intervals look okay to me. And then I'm kind of trying to look for any signs of ischemia. And so when you're looking like morphologies, like when you're trying to look for signs of ischemia, you want to be looking for like ST depressions or T wave inversions. And here it's a little tough for me to say. So lead 2, it looks like the T waves are inverted there. Lead 1 also has kind of some inverted T waves. Lead 3 looks kind of inverted. Let's see. So V2, if you look at that, you might be like, oh, is that ST segment elevated? But actually in V1 and V2, actually in V2 and V3, it could be pretty normal to have a slight ST elevation there. And so based on the patient's age, it kind of determines whether we're going to classify it as a true ST elevation or not. But most of the time, it's going to just be like a J point elevation is what we call it. And what else? So if I was considering a PE, the main thing I'd be looking for is, the pathognomonic pattern for PE, which would be the S1Q3T3 pattern. And so what you're looking for is an S wave in lead 1. So looks like we have a Q wave in lead 1 and an R wave, but no clear S wave. And then a Q3 T3. So then you're looking for a Q wave in T3. You kind of have this tiny little divot. I'm not sure if that would classify as a true Q wave just because of how small it is. And then inverted T wave, which we kind of have some flattened T waves there. And maybe that inverted T wave in that first after that first QRS complex there. But yeah, I would say this looks like sinus tachycardia to me. I'm not seeing like obvious signs of ischemia, but there are some T wave changes that I'm seeing. And I didn't classically see that S1Q3T3 pattern.
Yeah, that was like my read exactly. I was like, okay, I think it's sinus, so that's a good start. And I don't think there are signs of ischemia, maybe some LVH, but as you were saying, no obvious signs of PE on the EKG. I go and see the patient, and he's sitting in bed, he's on room air, very comfortable. His lungs were clear on auscultation. I asked him if he feels like his heart rate is beating fast, and he does say like, okay, I do feel like some palpitations, like my heart is beating fast. Like, okay, you leave the room. The CBC and chemistry were essentially normal, and I'm gonna pause there.
Yeah, so I mean, we're just not getting much signal for anything at this point. And because he had that surgery 3 days ago, I think we still need to be very on the lookout for a PE with sinus tachycardia. So we typically say that S1Q3T3 is like the pathognomonic EKG finding for a PE, but actually the most common finding that you'll see with a PE would just be regular sinus tachycardia. So it's like a common PIMP question that attendings will ask. Oh, what's the most common EKG finding with a PE? It's actually sinus tachycardia, not the S1Q3T3 pattern. The other thing I would check is, has this patient been on DVT prophylaxis? And I would say, the ortho teams are usually pretty good at making sure everybody's on DVT prophylaxis, but just something to double check, right? And then, at this point, I would definitely be wanting some imaging. A lot of times people do get really volume overloaded after surgeries because sometimes they do just like pump them with a ton of fluids, or they leave the fluid, like maintenance fluids, on for too long. So that's something to be on the lookout for. But the fact that he's on room air, he's breathing comfortably, his lungs sound clear, it sounds less likely that there's some kind of volume problem that's going on here. And also, we don't have a history of like heart failure or some other, predisposition to getting volume overloaded. But yeah, I think I'd pursue some imaging at this point.
Yeah, and about like tachycardia being the most common presentation for PE is something that we've all been pimped and asked about during medical school and intern year. So what type of imaging would you like to start with?
I think a chest X-ray is the easiest thing to just start with, so we could start with that.
Back to you, Yusuf.
Yeah, ask and you shall receive. You do get a chest X-ray, and I'm gonna show the image, but it's essentially normal. No infiltrates noted on the X-ray. No major like abnormalities there, and then we decide to go ahead and get a CTPE. And the patient actually is on VTE prophylaxis, like you mentioned. The ortho teams tend to have like a higher VTE prophylaxis dose. We're doing like low molecular weight heparin, 30 milligrams BID. And I'm gonna share the video for the CTPE right now. And I'm gonna pause at the like money shot. And the thing that I'm noting too is this thing in the left lower lobe.
Okay. So it looks like there's probably some consolidation on the left lower lobe, and looks like maybe there's like cavitary component to it. Is that what I'm seeing?
Yeah. So
It's not in
I'll give you
not in the lung view, but yeah.
Yeah. So I'll give you the official read, which may or may not be very helpful.
Yeah.
So the official read is sorry. The CTPE is obtained. It is limited by the contrast timing, but there's no definitive PE to the lobar level. There is a left lower lobe consolidation, but this consolidation may represent aspiration or pneumonia or atelectasis or infarct, and to correlate clinically.
Oh, interesting. And did they say that it looked cavitary, or was that just me imagining?
Yeah, they didn't comment on like cavitation. I think maybe it was just the window.
Oh, okay. Yeah. Unexpected. So no PE. I think it was very good that we got the CTPE, so we can just definitively rule that out. Right. That's good. Sorry. Right. That's going to be the most common thing that we're going to be worried about. Left lower lobe consolidation, just causing sinus tachycardia would be a little bit interesting. If it was some kind of left lower lobe pneumonia, you would expect them to be febrile, have a cough, have some kind of respiratory symptoms. So yeah, I'm trying to think about what I would do with this information. And we haven't had any clear history that he was aspirating or having like trouble swallowing after his procedure or anything like that.
Correct. And he's like very young. He's I think almost close to 40 years old.
Okay. And then an infarct is interesting to me because I'm thinking what could cause an infarct. So, the CTPE, they did say that it was limited by the contrast timing. Is it possible that it somehow missed a PE and, a PE led to an infarct there? That also seems a little bit strange to me. Yeah, I'm actually not entirely sure how to proceed with this case at this point. I feel like this is a really interesting situation. And it might be the situation where I just, sometimes we just need to give it a little bit more time and just like see what develops. I'm curious what you did in this situation and what you decided to do, Yusuf.
Yeah. I'm gonna share what I did, but I wanted to pick your brain as well. Is that okay? You're like, okay, maybe it's pneumonia, maybe it's an infarct. Would you start like antibiotics or anticoagulation at like this point in time?
Yeah, that's a great question. So for me, I'm not seeing any clear, clear signs that he has a pneumonia. He doesn't have a leukocytosis. He doesn't have a fever. He's not having like a productive cough. So I don't think I would necessarily start antibiotics at this time. Now, like, some people will like throw on procals just to like see, oh, what's the risk of infection? I think the actual like utility of that is, ID never really likes if you do that. Procal was really only validated for helping you stop antibiotics early. And so, sometimes people will do that. And like even and then like in a weird situation like this, maybe you could use that to like kind of help clarify things for you a little bit, or like maybe give you more argument towards one thing or the other. But yeah, I probably wouldn't start um, antibiotics at this point. And then in regards to anticoagulation, again, I'm not seeing a clear PE, so I'm not sure. But I don't have a clear explanation for the sinus tachycardia. So I might really just ask them, hey, I might call radiology and ask them, hey, is this actually like a good enough study to rule out PE? Is this something that we need to maybe repeat at some point? Um, and then yeah, I'm not sure.
Yeah, perfect. I purposefully chose like a situation where there's like no right answer. It's more like about like uncertainty. So
Yeah.
I went ahead and called radiology. I was like, oh, okay, hey, like I know you told me to correlate clinically, but do you think this is aspiration, pneumonia, or infarct? And they said that it's hard to say just from imaging. But they did say that the timing of the contrast was very limited and they cannot definitively rule out PE. And then so the next question I asked them was like, okay, if we can't rule it out, would you recommend like a VQ scan, or do you recommend we repeat the CTPE? So they actually recommended that we repeat the CTPE if the suspicion is high enough. And the thing that was bugging me was like you're saying, like, okay, PE causes tachycardia, but and we don't see any signs of like infection. So I wasn't sure. So I decided to like give the higher dose of the low molecular weight heparin that night. And I thought, okay, it's easy. Don't have to
Yeah,
do a
just in
heparin drip.
case.
Yeah. Just up the low molecular weight from like 30 mgs to like 1 mg per kg. And I spoke to my hematology friend. I was like, hey, what do you recommend? And he's like, okay, yeah, you can just like look for evidence for PE. So maybe get like lower extremity Dopplers, see if there's any evidence anywhere else that might like point you to the right direction. So in this case, I went ahead and ordered a repeat CTPE and Dopplers of the lower extremities. So Dopplers of the lower extremities did not show any DVT. We did do the repeat CTPE, and the repeat showed a filling defect within the left lower lobe, and the previously noted consolidation to be more likely representing an infarct. We got the TTE as well, which is not evidence-based, but in this case, it was the reason why we did it was it showed the CTP also showed dilated pulmonary artery. So I was like wondering if there's like a component of previous VTE or pulmonary hypertension. So we do get the echo, and the echo shows a dilated right ventricle with concern for possible like underlying pulmonary hypertension. And that's basically the end of the first case. And I'm just gonna pause there for like reflection or thoughts about it.
Yeah. This is a very interesting case. The other question I had was, did you guys end up getting a BNP and trope? Because sometimes that can also help in the workup of like these PEs.
Yeah, we did end up getting a BNP and a trope, and they were not significantly elevated. We were just trying to like you were saying. So in terms of management, we risk stratified the patients. We got the BNP and a trope, and they were not significantly elevated, and it was not a large enough defect to require an intervention, or in this case, like a thrombectomy, which has been shown to have some better outcomes if the PE is large. We ended up switching the patient from low molecular weight heparin to DOAC. Given that there was concern for pulmonary hypertension, we were wondering if the patient has CTEPH or a previous, like, does the patient have PEs previously that he did not know about? So the ultimate study for that is a VQ scan, but we could not do it inpatient, but we just discussed with the patient getting the VQ scan outpatient. And then we just reviewed the things that we need to rule out for any patient with pulmonary hypertension. So we got an HIV screening that was negative. We got a vitamin C level, and we got an ANA and antiphospholipid syndrome just because that would change management long term, most of which were negative, but the VQ scan has not been done yet.
Yeah, fantastic. Yeah, this is a great case. I think a couple of the learning points. So, first of all, whenever you are, not sure about the imaging result, you should really have a low threshold to discuss with your radiology colleagues about what to next proceed with. Do they think another study would be better? Do they think repeating the study would be good? Or, how much did they really think that this, the imaging was limited by the contrast timing? And so that was really helpful in this case. The other thing is, in general, in medical school, we learn about VQ scans, you know, as another potential way to diagnose PE without, giving contrast that might, cause any kidney injury or anything. But in general, the VQ scans, they're just not as accurate for, in clinical practice, we tend to use the CTPE a lot more because the VQ scans, if you remember in medical school, they always just give you like low probability or intermediate probability or like high probability. So they're not as helpful. So in this case, I can understand why they recommended a repeat CT scan. It is unfortunate that we had to expose him to radiation twice for it, but in the end, it ended up making the diagnosis. So it was definitely needed. But it sounds like for VQ scan for the work of pulmonary hypertension can be more useful. I actually am not totally as familiar with that side of things. The other thing you always want to work, keep in mind with these patients is if you do see the dilated right ventricle, dilated pulmonary artery, you have to ask yourself, are they having signs of right heart strain? And in this case, it sounded like this patient has chronically elevated right-sided pressures causing this. But if somebody has right heart strain, we kind of have different risk categories for pulmonary embolism. And with right heart strain, they may need more immediate intervention. For example, like a thrombectomy or a catheter-directed thrombolysis or systemic thrombolysis. So the main categories for PE, we used to call it non-massive, submassive, and massive PE. Massive PE would be the people who are like hemodynamically unstable. Non-massive is, completely stable. And then the submassive would have some signs of right heart strain, either elevated BNP, trope, or signs of right heart strain. A lot of times we do point of care ultrasound too. You can look for McDonald's sign or the D sign as other, signs of elevated right-sided pressures. Nowadays we're starting to call it like low risk, intermediate risk, and high risk PE. We're changing the terminology all the time. But yeah, that's definitely something you want to make sure of. The fact that he had a normal BNP and trope was definitely reassuring. So yeah, it seems like he has some interesting reason for some chronic pulmonary hypertension going on. But yeah, this is a great case.
Great case, Yusuf, and great discussion, Dr. Conan. And for everyone watching, Dr. Conan has a great video on PE and its classification on his YouTube channel that you guys should check out. And I think we can move to the next case if you guys are ready.
Yeah, I'm ready. Conan, since we have a small intermission, do you want to like tell us how hospital medicine has been, or people listening, like what do you enjoy about hospital medicine and why did you go into the field?
Oh yeah, I really like hospital medicine. I feel like the lifestyle has been really good. And the reason I chose it is because when I was going through medical school, I felt like I kind of liked all the different topics, and I didn't want to give up all the stuff that I learned throughout medical school. So I think medicine was like a really great way for me to retain a lot of that knowledge. I also really like working with medical students, and so everybody has to rotate through internal medicine. It's really nice to be able to interact with so many learners at different levels. So yeah, internal medicine has been a really great fit for me.
Awesome. If you're ready, we can go for the second case. This is a fun one too.
Yeah, definitely.
So this is a 76-year-old male, history of hypertension, diabetes, CKD, and COPD. He's presenting for dizziness and near syncope. So he reports that the day before he had multiple episodes of vomiting, and then he reported like shaking movements in his arms that began the day earlier. His he follows in our hospital. His home medications include amlodipine, metformin, dapagliflozin and gabapentin. He is retired and doesn't smoke or drink. And I'm gonna pause there.
So
Yeah,
Dr.
so
Oh,
oh, go ahead.
yeah,
Yeah.
I just wanted to ask, like, we can start like with your approach to like fall and near syncope before like talking more about like the HPI.
Yeah, so syncope, that's actually exactly what I was going to go into. Like, whenever I hear syncope, I kind of have this standard approach that these like main buckets that I think about. And so the first one being vasovagal syncope. Some people also call it neurocardiogenic, but vasovagal syncope. That's going to be the most common cause of syncope. It happens about 65% of patients. The next cause would be orthostatic hypotension or orthostatic syncope. That's going to be in about 15% of patients. And then the third cause or the third bucket is going to be cardiogenic causes of syncope. So that's about 10% of patients. And that's kind of whenever we admit patients for like a syncope workup, that's kind of like the main thing we're trying to rule out is like they didn't have some really dangerous arrhythmia that caused them to syncopize, or they didn't have some kind of like structural valvular, like severe aortic stenosis that's causing them to syncopize. So vasovagal, orthostatic, cardiogenic. And then 10%, the last 10% is kind of like other. So there's some like syncope mimickers, like seizures, or like certain kinds of strokes, or like subclavian steal syndrome. Like those are a little bit more like esoteric things. But typically the three main buckets are vasovagal, orthostatic, and cardiogenic. And then I could go into the different like history findings you would see with those. Should I go into those? Yeah, so my basic approach, the key things that you would want to look out for vasovagal syncope. So vasovagal syncope, a lot of times is going to be in response to some kind of trigger. So you want to look for that trigger, like, people who faint at the sight of blood, or they felt some very strong emotional event or saw something really scary and then they fainted. That's very classic for vasovagal. Also, if they've had a history as a kid of fainting, usually that's more consistent with vasovagal syncope as well. Prolonged periods of standing also are associated with vasovagal syncope. And then there's some kind of subtypes of vasovagal syncope. You'll see that a lot of patients will syncopize while they're urinating or while they are on the toilet having a bowel movement. So there's something we call Intermission syncope, which is basically when you're peeing. For some reason, it triggers this kind of vagal response, and people faint all the time when they're on the toilet. So we see that a lot. And then on board exams, there's this other kind where they describe this patient who has like a necktie that's tied too tight, and then they syncopize randomly during the daytime. That's because it's like pressing on their carotid artery and like causing them to have vasovagal syncope. And then for orthostatic syncope, a lot of times you're going to be, this guy kind of might fit that picture just based off his history. So orthostatic syncope, it's going to be people who have risk factors for autonomic dysfunction. So people with like long-standing diabetes, or have Parkinson's disease, or even just age. As people get older, they start getting autonomic dysfunction. They're at higher risk for orthostatic syncope. And then, of course, the classic history finding you'll see is, recent decrease in oral intake, or also, rising quickly from a standing position. That is also like a common thing that you're going to see with orthostatic syncope. I also forgot to mention for vasovagal syncope, one thing that we look for is a prodrome. So a prodrome being like they feel really warm or flushed. They feel like, sweaty before they syncopize. And then orthostatic syncope, actually, a lot of times when they stand up too quickly, they also do feel like symptoms of lightheadedness before they faint. This is in contrast to cardiogenic syncope, which the main important thing that you want to look for cardiogenic syncope is that it's sudden loss of consciousness. That's one of the biggest differentiating factors from vasovagal, orthostatic syncope, which are kind of more benign causes, versus cardiogenic. You want to look for that sudden loss of consciousness. Other concerning history findings for cardiogenic syncope are things like exertional syncope. So let's say somebody is like mowing their lawn and they're like really tired. And if you think about like maybe they're having like cardiac ischemia or something, and that then they like syncopize. So exertional syncope, supine syncope. So they're just lying in bed and they syncopize. That's also very concerning. Because again, if you look at vasovagal and orthostatic, usually those are with like standing up. They usually don't happen if somebody's just lying in bed. So if somebody syncopizes while they're lying in bed, it could be very much more likely to be a cardiac issue, because you can have an arrhythmia at any time. You don't have to be standing. You could be like lying down. You could be sitting down. Um, so that's definitely something that's concerning. And then, of course, any cardiac history, any family history of sudden cardiac death or sudden drownings or unexpected drownings. Those are things we look for. So family or personal history of cardiac disease.
Wow, great pros and teaching on syncope and the different types. Now, like, what do you make of the multiple episodes of vomiting and the shaking in his arms? Like, how can you integrate this with his presentation, syncope and fall?
Yeah, so the multiple episodes of vomiting, for me, it's kind of making me question, is this, did he get like a recent viral infection, like a gastroenteritis, and he's vomiting a lot? And now he's had poor PO intake. Now he's like volume down, and this could put him at risk for orthostatic syncope. And then the shaking in his arms, I'm curious, like, was that like after the episode of syncope he was shaking a little bit, or was he like having shaking movements before the syncope? Yeah, what was the exact timing of the shaking?
Uh, Hopefully, I'll give you more information in the next aliquot. That will
Okay,
be
yeah.
that will be enlightening. So
Yeah.
let me just jump to it. So the patient arrives in the ED. His blood pressure was 111/61. His heart rate was 64. He had normal O2 sat, and then his exam was normal except for notable asterixis. So I would put his hand out, and he would have like shaking movements. And he also he was feeling having like whole body asterix, like his head was shaking a little bit, and he was having like asterixis with movement as well. On the first set of labs, his creatinine was 2.2, so up from a baseline of 1.3. His serum protein was normal, his serum albumin was normal, his hemoglobin was normal, his MCV was normal, his platelet count was normal, his INR was within normal limits. And in terms of like characterizing these movements, he said he's never had this before, never had these like movements before, and he was like surprised. He said he felt like it started yesterday, like after the episodes of vomiting.
Yeah, wow, interesting. Yeah, interesting turn, definitely. So asterixis, of course, the most common thing we think about is like with hepatic encephalopathy, but like multiple causes of encephalopathy can cause asterixis. So uremia can also cause asterixis. And I only recently learned this, but CO2 narcosis, if you have like elevated CO2 levels, it can also cause asterixis. Asterixis in the whole body, including the head. I can't say that I've ever seen that before, that severe of asterixis where the whole, like the head is being involved. Um, so definitely interesting. I definitely do want to know what his BUN is. Okay, so it's 33. You did mention it was only 33? Okay, so yeah, because at first I was thinking with the vomiting and asterixis, that could fit with uremia, because uremia causes vomiting as well. However, with a creatinine of 2.1, you probably wouldn't expect like such a high, like a super high BUN that you would be uremic from it. Um, so the other things I would want to check, I'd want to check his VBG just to see, other causes of this asterixis, and just see like the rest of his labs. Looks like his CBC was normal. And then, yeah, liver function tests, see what's going on there. Let's see what else. And the shaking started after the vomiting, is what you said?
Correct.
Okay. Yeah, and I definitely want to know his acid base status. I think, maybe if he's like very acidemic or or if he's alkalotic from the vomiting. Yeah, maybe those are some like uncommon causes of asterixis that we would want to take a look at.
Yeah, I'll ask and you shall receive. So I was thinking on the same lines. I got like an ammonia level that was normal, and then the INR was normal, and none of the like synthetic liver markers were abnormal as well. No history of liver disease. I got a VBG. So the VBG does show some acidosis. So his pH was 7.25 with an elevated CO2 to 60. His baseline of previous VBG was actually normal, and of note, his lung exam was normal. So on further questioning, he reports that after the episode of vomiting, he thought that maybe he could like self-treat with like gabapentin, and he actually ingested, instead of like one tablet of gabapentin, he took 3. So he took 1,800 milligrams at once. And I'll pause there.
Oh yeah, that's a great point that I missed earlier. So we should also look for like drug-related causes or medication-related causes of asterixis or encephalopathy. 1,800 milligrams is a very high dose just to take in one go, especially if you have CKD, because usually for gabapentin we have to renally dose it. So that could definitely be causing some kind of asterixis picture as well. And then he's also, he's got a mild acidemia as well with CO2 retention. So he has like multiple different reasons that could be causing this asterixis. So the first thing I would want to do is, I'd probably want to try and correct his CO2 retention a little bit, even though his lung sounds are normal right now. I would just start giving him some duonebs and breathing treatments, just try to help him breathe off some of that CO2. And if it's not working, just start off with some breathing treatments, see if we can get some more air movement going. The gabapentin hopefully will slowly start to wash out a little bit. I think that's what I would start with.
Awesome. So similarly, it was like very unique. Like, why is he having CO2 retention, but his lung is not having like a terrible COPD exacerbation? And we were thinking about the like indications for BiPAP, or should we just give him some time and see if he can breathe it off? So we did similar to what you did. It's like, okay, let's just do some nebs and we'll check later on. We gave him some nebs. The VBG the next day was actually normal, like went back to normal, and his asterixis slowly resolved. And upon like further reading, gabapentin causes asterixis if it is ingested, but it actually causes it via 2 mechanisms. So the first mechanism is that it directly causes GABA activity, which can cause asterixis. But the other mechanism is that it can cause CO2 retention in a vulnerable host. So this patient's COPD put him at risk, and then our theory was that he had gastroenteritis with vomiting, developed an AKI, had this extra dose of gabapentin, ingested it, which caused to accumulation. And then in severe forms of asterixis, you can have a whole body shakes as well. So in this case, that's what happened. Had CO2 retention and had GABAergic direct causing asterixis. And that was the end of the case. So I'd love to hear your reflections.
Yeah, that's a very interesting case. It was very multifactorial. I like the twists and turns that it had throughout the case. Um, can you describe again with the whole body shaking or like the head shaking? I kind of missed that part. I kind of wanted to hear that part again.
Yeah, I think it's just really profound asterixis. So if somebody has like really bad asterixis, it can cause more than just the hand to shake. It can also affect your head, or like also like some head bobbing type of activity as well.
Yeah, and he wasn't confused at all. He was like oriented.
Correct.
Yeah, I would say, asterixis, just be aware that there are multiple other causes of asterixis besides just the classic that we think about of hepatic encephalopathy. There's so much just-in-time learning, right? Like I only recently found out that CO2, like maybe I should have known this, but I didn't typically think of like CO2 retention causing asterixis. But now, this is like just kind of further reinforcement that that's definitely an entity you should be on the lookout for. And so you'll notice like throughout your career that like you'll start picking up these like little factoids over and over and over, and then they get reinforced. So you just gotta try and hold on to those pearls. Definitely don't forget to look at the medications. I totally forgot to address that he was on gabapentin, and that was a very big dose with that AKI going on as well. And then the other thing I always like to teach with asterixis, sometimes in hepatic encephalopathy people or patients, it can be difficult to test asterixis because they're extremely altered. They can't follow commands to like hold their hands out like they're stopping traffic. So one of the alternatives is to do what's called the milkmaid's grip, where you just have them squeeze your fingers, and it's a little bit easier for them to follow commands like just squeeze your fingers. And if you feel this like contractile like release and like tension, and it's kind of this rhythmic contraction, that's also consistent with asterixis. And that, again, that exam test is called milkmaid's grip.
I love it. And the other thing I thought of as well is that in this case, we see like in the acute setting, gabapentin can cause CO2 retention. But now more studies are coming up that in patients with COPD, if they are on gabapentin, they're more likely to have hospitalizations. It increases the risk of hospitalization. And this is one of the mechanisms. So they retain more CO2 and they get hospitalized more frequently. So nowadays we're trying to discontinue gabapentin, especially if patients have a history of COPD.
Yeah, that's fantastic. I actually didn't know about the CO2 retention with gabapentin, so that's definitely another pearl I need to file away.
Amazing teaching by the both of you. Dr. Conan, would you like to share 2 to 3 pearls from the 2 cases that you discussed today? Just
Yeah,
to summarize.
I mean, just to summarize, the first case was a case of tachycardia after femur fracture in a post-op patient. Even though, we didn't see obvious signs of a PE, you just have to like, just based on the history, you just have to have a high suspicion for it and just have a really low threshold to get that CT scan. And then when the CT scan doesn't show what you might have expected or shows something unexpected, have a low threshold also to talk to your radiology colleagues and consider repeating the test. Um, so yeah, just a very important patient demographic that we take care of. And then in the second case, just remember the different causes of asterixis, that there's multiple ones besides just the classic hepatic encephalopathy. Always keep medications on your differential, and yeah, take home this new learning point that gabapentin can cause CO2 retention, which so this guy had like 3 different mechanisms for which he was having asterixis. So very interesting case.
I love your reflections. I was going to order a stat neurology consult. Dr. Helen, she wanted to give us some comments on asterixis.
Oh, great case, Yusuf and Conan. I'm Helen Shee. I'm a neurologist at Emory University Hospital, and I'm also Conan's sister-in-law. This case, I just wanted to take a moment to talk for a moment about myoclonus, which is my favorite movement disorder as an inpatient neurologist. Myoclonus is all over the hospital. So myoclonus is an intermittent irregular jerk that can occur in any muscle group. We have positive myoclonus, and then we also have negative myoclonus. Negative myoclonus is a sudden loss of muscle tone in a muscle that's activated. And so when you're having somebody activate their upper extremities, you're having them hold their arm up in front and, their arm is extended, their wrist is flexed back, fingers are extended. That allows for maximal activation of those upper extremity muscle groups. And when so it's the best way to elicit that sudden loss of muscle tone. And so when you see that, like tremoring of the fingers or that loss of tone in the fingers or at the wrists, then that is negative myoclonus. So asterixis is one form of negative myoclonus, but negative myoclonus can happen anywhere in the body, including if you have somebody who's just sitting upright, their neck is upright, they can have loss of tone of their neck, they can have loss of tone of their legs. If you're checking for leg drift, have them lift up their leg and they lose muscle tone. We also have positive myoclonus, which is when somebody has a muscle that's at rest, and then suddenly there's a jerk that is a sudden activation of that muscle group. So there's positive myoclonus and negative myoclonus. Typically, negative myoclonus is due to toxic metabolic issues like the uremia, the hypercapnia in this patient, and also medication. So negative myoclonus most typically is cortical. And so it's usually the brain, like the cortex of the brain, bathed in bad humors of uremia, hyperammonemia, hypoxia, hypercarbia, gabapentinoids like Lyrica, gabapentin, opiates. Those are all the big offenders. With positive myoclonus, it can be from these toxins affecting the cortex, or it could be subcortical, spinal, or segmental, so individual nerve roots. So somebody who's developing shingles of a nerve root, they can have myoclonus of that nerve. You know, my own mother had this when she had shingles on her chest, and she had this twitching on her chest wall that no person is able to volitionally perform. But when she had shingles, she had this positive muscle contraction of that was uncontrollable over her chest wall where the shingles was setting in. Or somebody who has, you know, an epidural hematoma or a spinal cord issue, like they have a spinal cord infarct, they can develop myoclonus in the legs and have twitching, or, myoclonus below that level and have intermittent irregular jerks. And so just want to make everybody aware of myoclonus. Can be positive myoclonus, which is activation of a muscle group at rest, or negative myoclonus, which is a sudden loss of muscle tone of a muscle that's activated. With negative myoclonus, think about toxic metabolic stuff bathing the brain. With positive myoclonus, think about what muscle groups are involved and where could I localize that most focally. You know, if it's just one body part, for example, somebody's hand has intermittent positive and negative myoclonus, well, that could be a structural lesion in the contralateral cortex, which we definitely find. Myoclonus is all over the hospital. You guys just, if you pay attention, you'll see it. Lots of people have myoclonus going on, especially from toxic metabolic things like AKIs and opiates and gabapentinoids.
Thank you so much, Dr. Helen Chi, for your input and the amazing teaching behind myoclonus. Thank you so much, Dr. Conan Liu, for being our guest today. It was such a fun hour, and we would love to have you again here. And Yusuf, thank you so much for not just like presenting one case, but two nice cases, highly educational. And thank you everyone for joining us.
Thank you so much.